All right. Well, good morning. Welcome everybody that's made it to this talk. I'm excited to have Dr. Kadish back virtually. So some of us know him that he trained here as a resident and then moved on to Utah for a neuroimmunology fellowship, and then is on faculty there at University of Utah in the neuroimmunology division. I'm happy to have him back. I would have preferred this to have a coffee this morning and a beer tonight together, but we'll have that another time. Everybody else, enjoy your hot beverages in a treacherous morning, so hopefully people are safe and enjoying a drink. So he did have this, what'd you call it? A
word cloud.
Word cloud. So if you see it on the screen, sign up for the word cloud so that it can be interactive. Good morning, and Dr. Kadish, thanks for being here.
Yeah, thanks so much, David. Thanks for that very nice introduction, and it's really a special moment for me to be able to come back and visit, even if it is virtually. And I can already see some names on the screen that I recognize, so just want to shout out to everybody. Had an excellent clinical training here, and especially shout out to David Roberts and Michael Sweeney for getting me to where I am right now. So I'm going to go ahead and pause the word cloud and move on, because it is going to be a little bit of a whirlwind tour, and I don't know if I'll be able to see your chat. So I'm happy to answer questions or look at the chat after the presentation. All right. So like I said, I want this to be a boots on the ground approach to autoimmune neurology, and it will be a whirlwind approach. So hold on tight. This is a picture of my beautiful city, Salt Lake City here. And what I'm going to talk about is autoimmune neurology. So autoimmune neurology is exciting, rewarding, and confusing, unfortunately. Now, I hope to dispel some of that confusion as we go through this talk. And the topics that I'm going to focus on today are in this blue rectangle here. So I'm going to talk about autoimmune encephalitis, which I'm going to include both perineoplastic, non-perineoplastic variants. And then I'm going to talk about neuromyelitis optica and myelin oligodendrocyte glycoprotein antibody disease. Now, it's going to be a lot to take in, but I think it's important to cover it because it's something that you will see inpatient and outpatient. And it's becoming more and more, we're recognizing it more and more. So going into autoimmune encephalitis, now this is a term that, people have heard ad nauseum probably at this stage. So I'm not going to talk too much about the theoretical perspectives, other than making a very stark contrast right at the start between two somewhat separate pathways of autoimmune encephalitis. So on the right-hand side of the screen, we're going to look at first the intracellular antigens. And, what needs to be said at this stage, that I'm not going to delve too much into, is that these are autoimmune conditions. So we're talking about a confused immune system. We're talking about basically activation of the immune system inappropriately against self. So molecular mimicry is the key word that I think everyone at the University of Louisville is familiar with. So when we talk about intracellular antigens, in this case, these are going to be our classical perineoplastic conditions or autoimmune neurological conditions associated with neoplasia or cancer. And starkly compare and contrast that with the cell surface antigens and synaptic antigens, which are not always, and I would say mostly, not as associated with cancer as the intracellular antigens. And here below, you'll see a staining pattern that's characteristic of each of these. So this is a neuron, and you can see the cell surface kind of staining, whereas here with the intracellular antigens, you can see the nuclear staining pattern. And let's go on more so to see why exactly this is important, this contrast between the two. So as far as your cell surface antigens, you're having here in this category, you have your classic NMDA, LGI1, proteins. And then on the intracellular perineoplastic cases, these are your classic Hu, Yo, Re, Ma. Now, like I mentioned, there's a variable cancer relation in the cell surface antigens. These are primarily a humoral mediated response, so antibody mediated. And response to treatment, fortunately, is quite good in many of these cases, although you can't always say that. Now, when you compare that with the perineoplastic conditions, there's a primary T cell response with secondary B cell responses. And unfortunately, these cases are delayed in diagnosis, and there's unfortunately a poor response to treatment. Okay, so throughout the presentation, I'm going to try to provide some highlights, some things that you need to think about, and putting things into perspective clinically. So as far as the intracellular antigens, the classical perineoplastic cases, they develop or are found. These auto antibodies are found in up to 2/3 of cases. So keep that in mind. And this is very much a field that is not black and white. So some of these perineoplastic, we know that a lot of these autoantibodies have perineoplastic relation, like anti-Hu, Ma, Yo, but some of the other the cell surface antigens, for example, can also be perineoplastic as well. Something that's well known is the NMDA receptor encephalitis, the association with ovarian teratoma. However, this is not, there are no absolutes in this field, I would say, and depending on the clinical situation, whether a patient has cancer risk factors, is an older age, these may raise the likelihood of co-occurrence of neoplasia. And in neurology, we all love our tests dearly, our diagnostic tests dearly, but we can't rely on them, at least the basic CSF studies. So this graph here shows just how heterogeneous basic lumbar puncture results can be in these autoimmune encephalitides. For example, a systematic review in 21 studies for NMDA receptor encephalitis showed that almost no, well, actually here it shows 0 CSF were normal. So every CSF sample was abnormal in some way. Compare and contrast that to Lgi1 mediated autoimmune encephalitis, which mostly has a normal CSF profile. And there are other things that we love, right? The trifecta of neurology diagnostics, the lumbar puncture, the MRI, the EEG. So these are variably helpful, unfortunately. For example, in an NMDA receptor encephalitis, MRIs have a relatively low sensitivity, whereas in Lgi1, they may be slightly more sensitive. EEG results can be helpful. They can also not be helpful. And when we perform systemic neoplasia screening, systemic malignancy screening, we like to combine a metabolic imaging type, PET, with a structural imaging type, CT. And that's because sensitivity may be increased 10 to 20% in cases, especially where you don't detect something the first go around with CT. Now, what I really like about this field, during residency, I love general neurology. So I like MS, I like other autoimmune neurological disorders, but I also loved other neurology, and I like medicine as a whole. So in autoimmune neurology, you really have to stay up to date with general neurology and medicine as a whole, actually. And we'll see that throughout the coming cases. So let me quickly go through these slides just to provide some perspective of where we come from, where we are. So with autoimmune encephalitis, we really are standing on the shoulders of giants in the field of medicine as a whole. In the late 1800s, individuals were already suspecting that there's a spooky at-distance effect from cancer that could not be directly explained. Later into the 1900s, there are cases popping up like Wilkinson and Zoromsky describe of subacute sensory neuronopathy and lung cancer, which probably later turn out to be anti-Hu in the 80s. Now, this is a somewhat dizzying slide because what you're seeing here is during the 70s, 80s, 90s, or early 90s, we're focusing a lot on the classical perineoplastic intracellular targeting types. But after that, the 90s, 2000s, going on afterward, it is mostly cell surface or synaptic-based autoimmunity that we're looking at here, and it's exploded. So every year we're gaining about 1 to 2, maybe even more new autoantibodies to the repertoire. So this slide's also important because I'm going to highlight first here that you need not think of certain antibodies when you try to diagnose a patient. That's not the point. So also some perspective is that especially in young individuals with undiagnosed encephalitides, autoimmune encephalitis is quite common, quite relatively common, as shown in the California Encephalitis Project. And then we also have some updated data showing that the detection of this condition is increasing over time, and the prevalence and incidence is somewhat similar to infectious encephalitis, actually. Now, when we look at autoimmune encephalitis, like I said, don't worry too much about the specific autoantibodies. You need to recognize the clinical syndrome early. And the clinical syndrome can be variable. And another reason actually not to pay attention to the autoantibodies is because the clinical presentation does not always predict a specific antibody. There can be overlap. But you need to know general presentations of neurological disease. Okay. So going to your toolkit, your biggest asset here is going to be your clinical exam, your history and exam. And in classical neurological disorders, the history has been described to be about 80% of the cake, so to speak, and the exam will follow. I would argue in autoimmune neurology, it's probably 90% history or even more. That's how important it is. So in 2016, Grouse et al. Proposed a diagnostic criteria for possible autoimmune encephalitis. And that features a subacute onset of memory deficits or psychiatric symptoms or mental status changes, and CNS findings listed below. So focal findings, seizures, CSF abnormalities, MRI findings. But the most important part about this is the reasonable exclusion of alternative causes. Again, going back to keeping your differential open, having a great working diagnosis, or using the term working diagnosis even from the start and revisiting the diagnosis. Some things I often forget to ask about in the history are cancer risk factors, whether the patient is a smoker, whether their screenings, age-appropriate screenings are up to date. These are very important things to ask about, and they can take time. I do respect that, but they're important to ask about. Family history-wise, things that are sometimes not reported and that you have to ask about specifically are vitiligo and thyroid conditions that are autoimmune mediated. Symptoms such as dysautonomia, as much as some of us may groan about dysautonomia, these are very important symptoms to ask about. So also sleep and brainstem symptoms need to be asked about as well. So go ahead and read up on those if you don't know about those. We don't have time to talk about them too much today. And the last fact is that these conditions, even though the diagnostic criteria talks about a subacute course, you have to consider patients that have not yet sought care, that have had sublethal insults that may be around and may have more of a progressive or stuttering course. Now let's dig right into the cases, okay?
Ready?
So this is a patient with 1 month of progressive ataxia and a new uterine mass. 7 years prior, she had breast cancer, status post mastectomy, which was treated. And you can see the degree of ataxia, finger to nose here, and on the left side, the wide-based ataxic gait there. Okay, I'm going to cut the video here. We can always revisit these videos in the end if they didn't come through or whatever. Now, this patient actually came in about 2 months after multiple hospital visits, being discharged without finding anything, and then came into our institution, and our diagnostics at that time included spinal fluid, where I've highlighted the pertinent abnormalities. So 5 CSF isolated oligoclonal bands, and then a high titer of both serum and CSF anti-Yo autoantibody levels. The MRI brain was unremarkable, but unfortunately, malignancy screening did reveal a uterine mass with multiple mets, and one of these lymph nodes was sampled and showed high-grade serous carcinoma of gynecological origin. So let's take a quick break there before we go on to more talk about this case. So paradigms in screening for perineoplastic conditions for the malignancy portion include a really good start with CT chest and pelvis, but as I mentioned before, adding a metabolic portion, the PET part, or vice versa, adding the structural portion, the CT to the PET, can increase the diagnostic yield by as much as 20%. We don't have enough time to go into it, but there are pitfalls of all of these scans to know, but this is a good paradigm. And what you need to know in cases of highly suspected perineoplastic conditions, you may want to screen your cases up to 5 years, especially if you don't discover anything the first time around. This is just a handy slide that I like to look at to see what the appropriate radiological screen for a certain type of cancer or body part is. Now, back to our case, our very, very dramatically ataxic patient came in about 1 to 2 months after symptoms. The subacute course was recognized at that time of the extreme cerebellar symptoms, and the kitchen sink, so to speak, was thrown at her. Now, as cancer was also discovered at that time, palliative chemotherapy was begun. She did derive some benefit from the immunotherapy, but it wasn't durable. So 4 months later, she was readmitted for another cycle of IV methylpred and plasma exchange. Again, some possible benefit. So admitted third time 3 months later, and unfortunately passed away sometime thereafter. So like we are already suspecting or have seen by the CSF screens there, this is a case of anti-Yo perineoplastic cerebellar degeneration. And this is about as dramatic as you can see of an ataxic picture in a subacute case. So these are going to be your people who are toppling when even sitting, they can't get up. It's an extreme clinical syndrome of cerebellar degeneration. And very few individuals, even at time of initial presentation, are independent. Unfortunately, because this is such a rare condition, either fortunately or unfortunately, rather, it is hard to study it. And most cases have been found after diagnostic delay when there has already been pathologically irreversible Purkinje cell degeneration. So even though we're about 30, 40 years out from its initial discovery in 1983, our best ideas of treatment are still not clear, but there is a strong suggestion of early treatment before those Purkinje cells irreversibly die. Okay, next case.
There you go.
So look at his left arm and face. Okay, see that? All right. So this patient presented quite acutely to subacutely with these very frequent movements. And CSF testing and serum testing did reveal positive results for Lgi1 autoantibody. And this, as we'll come to find out, is strongly associated with what we call facio-brachiodistonic seizures. MRI did show hyperintensity in the left medial temporal lobe here. It's a little bit hard to appreciate, but you can see a little bit asymmetry there, as well as slightly more full features. Metabolic imaging did show hyper-metabolic area there, and several months later, there was some relative atrophy on the left side. Now, the patient at that time, the clinical syndrome was recognized, and the IV methylprednisolone IVIG was given with some benefit at the time. However, several months later, the MoCA, or cognitive assessment for the patient, was quite abysmal, 7 out of 30. At that time, rituximab was administered, and MoCA steadily increased, 18 out of 30, and then to 26 out of 30. And several years later, the patient has very minimal cognitive impairment. So had a quite good recovery to immunotherapy, but did need long-term immunotherapy. So anti-Lgi1 encephalitis is one of the classic cell surface autoantibody-mediated conditions. And 90% of these cases are autoimmune, true autoimmune / not cancer associated. And the course here is nice to illustrate because it really parallels several cell surface mediated conditions in that there's a wind-up phase of symptoms and then a maximum with seizures or other catastrophic events, and then a gradual improvement even with immunotherapy and some residual symptoms thereafter. But we do know from literature that there's a very strong potential for early intervention as far as outcomes, and patients can relapse in the long term. Now, third case, a case of a 52-year-old gentleman with multiple myeloma that we think is well treated with 3 weeks of subacute headache, vision changes culminating in a seizure. CSF showed a phenomenon called matching bands, which may indicate systemic autoimmunity. And EEG, however, did reveal something interesting, that of focal right slowing and periodic discharges. Now look at this MRI. So my first thoughts coming into fellowship were, especially when I saw cases like this, were, this is not autoimmune encephalitis. This is so angry looking. This is something infectious. This is something neoplastic. So this is a case that is a little bit different, at least in imaging. So that was initial image. So I want to show you treatment response now. On the image on the video on the left will be the original, and the video on the right will be the post-treatment response. And this was a 3-month difference in MRIs, and an EEG was also done at the 3-month mark. And MRI shows essentially rapid improvement, almost, I would say, back to normal. And EEG also normalized at that time after the immunotherapy that was listed here. And the patient currently is on rituximab and is being followed with oncology for surveillance for multiple myeloma. So this is a case of GABA-A receptor autoimmune encephalitis. And like I mentioned, MRI-wise, this is a little different because findings can be tumefactive, fulminant, very, very concerning. You don't want to see this on a call night, essentially. But fortunately, it has a very good response to immunotherapy. Now, the takeaway point here is that this is a research-only test. So you will need to get in contact with UPenn when you have a high suspicion of this to test the CSF and serum. Okay, case number 4. So this patient has a storied history of a neuroendocrine tumor in 2012 with recurrence in 2014. This was a small bowel neuroendocrine tumor. And in 2015, when things were thought to be taken care of in remission, started some insidious mild twitching. Cognitive decline started sometime after that, but things really came to a head in 2020 with worsening chorea and dystonia that you saw in the video here. Now, it turns out that, unknown to us at the time, that PET scan had shown some metabolic areas that were concerning already. Chromogranin, which is a marker of neuroendocrine tumors, had been increasing steadily. We weren't privy to that initially. So follow-up PET scan showed hepatic mets, and other workup, serum CSF at that time was unremarkable. He did get the immunotherapy treatment and actually had a 40% improvement. And this is someone that just recently actually got discharged. So we'll see how things go on that aspect, but they're considering a chemotherapy for the cancer treatment that they've now found again. So these are important things to consider, that this can be an acute on chronic stuttering course, and you need to have early intervention for clinical-based suspicion of these conditions, for these quote-unquote seronegative conditions. This is a little bit of a different case again. Symptoms that go back even 15 years, different visual symptoms, 10 years of word finding difficulty. And this patient, even before coming to our institution, had extensive testing elsewhere, which was relatively unremarkable other than the MEG scan, which potentially suggested a subtle epilepsy. However, that was not able to be confirmed in any other way. Over 10 years into the course, the patient develops increasing stiffness and cramping, here seen in the toes. Further serological and other diagnostics were negative at that point. But the field moves along, whether we like it or not, and a new autoantibody is discovered. And in this case, it is the glycine receptor antibody associated with some stiff person syndrome symptoms. Now, autoimmune conditions tend to cluster together. The family likes to stay together, and sarcoidosis was also discovered in this person with PET scan. So this is a case, again, of a long-standing course of various symptoms with underlying autoimmune etiology. And this also represents bench-to-bedside medicine here. So the glycine receptor, now to know this is actually not present in the Mayo encephalopathy panel. It's a separate test that has recently been commercialized. Okay. So something now we've seen a lot, and I think probably with the COVID season too, is the link between infections and autoimmunity. So this particular gentleman had 4 years of behavioral change, which culminated, well, initially it was 2 years of behavioral change, which culminated in a diagnosis of PCR positive HSV encephalitis. It was treated well, purportedly. However, sometime after that, the patient continued to decline, had odd paranoia and other behavioral type symptoms. And the exam was, when seen in patient, was Parkinsonian, also with myoclonus and perseveration. CSF results were impressive for the above, and what we saw on the MRI was the old right-sided temporal changes, but also some left-sided temporal changes. Now, unfortunately, this patient did pass away because I believe it was pulmonary embolus. But staining based off of tissue staining at the Mayo Clinic from the CSF did hint at uncharacterized autoantibody. And indeed, when autopsy was performed, it was remarkable for chronic active encephalitis with no evidence of viral changes, and there was also no evidence of neurodegenerative pathology. So this leads us to the quote-unquote seronegative or unclassified antibody conditions. And things to remember about that is just because they're unclassified right now doesn't mean that they won't be in the future, or it doesn't mean that we won't have a name for them in the future. So again, clinical based diagnosis and early treatment. And did you know that about close to a third of patients with HSV encephalitis within 2 months experience an NMDA receptor type encephalitis with antibody positivity? So that's what this paper shows. And it's also, I paired this also with this other paper here about the UCSF metagenomic screening for infections, which can be helpful in infections that are odd or chronic. And a lot of times this can be on your differential with autoimmune or inflammatory neurological conditions. Now, I want to go through a couple of cases just to highlight a couple things. So this first case is a gentleman with prostate cancer remission, your classic 3 months subacute neurological symptoms, and we find a small pulmonary nodule. And so we all freak out and we need to go biopsy that and so forth, right? Well, not quite. So MRI this time does show something, and it shows T2 hyperintensities in the basal ganglia with corresponding diffusion restriction. So this is a case of CJD, but as you can see from the clinical symptoms, they're very much in line with possible autoimmune encephalitis. So keep your differential open, and RT-QuIC subsequently did return positive, highly indicative of CJD. Parallel that to case number 2, and most of the symptoms actually came after this third bullet point here. So he came in with a 3-month history of tremor, movement disorders, inability to walk, and memory problems. That's the similar exam to what I described. Also had some eye movement abnormalities. However, when you start to work up this patient, you quickly start to notice some differences. MRIs over several months are unremarkable, and the lumbar puncture was quite impressive for pleocytosis and restricted oligoclonal bands. Early IV methylprednisolone resulted in dramatic improvement. So he had a clinical picture similar to that first woman that I showed you, the extreme ataxia. And on day 2, he was able to walk, wide-based, but able to walk by himself. So quite dramatic improvement. And later on, he was just recently seen, he was started on cellceptor mycophenolate. So this actually represents a case of anti-GFAP astrocytopathy, GFAP astrocytopathy, somewhat recently described. It is a true meningoencephalomyelitis and can also cause pretty severe optic disc edema. In his case, it was masquerading as a CJD mimic. And so this test came back 2 weeks later, but fortunately he was treated early and he continues well. So really good immunotherapy response in this condition. Case 3 mimics case 3 is a T2 hyperintensity in the medial temporal lobe, which again makes you suspicious in a lot of cases, but other things can do that. A lymph node biopsy was benign, so the patient was initially treated as autoimmune encephalitis. However, 2 months later, things look quite different, and indeed this was a GBM. Turns out this is a pretty common occurrence in the literature, and the review showed that, did show that as well. And so really the important point here is close clinical follow-up. Now, moving on to what's in store for the future. a lot of what's driving this is research on the long-term impact of these conditions. So for NMDA receptor encephalitis specifically, poor prognostic factors include no treatment effect within 4 weeks, so basically not escalating to anything more, or no treatment at all within 4 weeks. Those are a couple of big things. So randomized control trials were planned back in 2020, and unfortunately, the IVIG trial failed to recruit the number needed, but even with the small sample size for LGI1 Casper-related epilepsy for individuals still having seizures up to twice a week, did show benefit of IVIG versus placebo. So that was the first study that helped insurance be a little less stingy on IVIG approval. Now, opening things up to prime time is a current study that is in the phases, NeuroNext, NIH, and that is the NMDA receptor encephalitis trial, looking at biomarkers, outcomes, and the treatment there is inebilizumab, which is a CD19 agent, and compared to placebo. And we're not going to get into the details of it, but this is a multi-center trial, hoping for really good recruitment. Really, really excited that this is in the plans and hopefully will move forward. Okay. Now, what would a talk be without quickly mentioning Nmosd and MOGAD, at least in the autoimmune world? So Nmosd or neuromyelitis optica. So even back in the 2000s, before autoantibody testing for this condition, there was still some question whether it was a relapsing condition at all. And indeed, this Mayo 2000 study did show that 75% of people presented just like this. Each little dot or circle represents a relapse, and each line is a patient. So it's a relapsing, severely disabling, potentially deadly condition. Now, contrast that to just some recent data that we have here at the University of Utah. So you can see that these lines, in this case, indicate individuals also on immunotherapy long-term, and they don't really have a lot of blips or dots or circles or whatnot, indicating, in general, quite a good response to immunotherapy. Now, for NMO especially, acute therapy should be of the type of hit them hard, hit them fast, hit them hard for good long-term outcomes. So traditionally starting with IV methylpred, but you want to have a very low index of, or a very low threshold rather, to start plasma exchange. And there's quite a lot of evidence in this arena, because especially with individuals with more severe relapses, those that are given IV methylprednisone plus plasma exchange, they tend to do much, much better 1 year afterward in terms of disability. So since 2019, NMO, Aquaporin4 positive NMO has experienced a boon, really, because now we have 3 FDA-approved immunotherapies: eculizumab, inebilizumab, and sartrilizumab. And that really begs the question, where does rituximab fall into this? Well, rituximab, we know from other studies, and actually somewhat recently, ironically, it took so long to get a small randomized control trial, I believe in Japan, it still shows it's quite effective. So eculizumab is a every 2-week IV infusion. So it can be not as convenient. Sartrilizumab is an every 2-week sub-Q, and 4-week sub-Q, and inebilizumab is more of your rituximab-based dosing every 6 months. All are effective, all are expensive, but overall the side effect profile is quite good. So quickly spending some time on MOGAD, or myelin oligodendrocyte glycoprotein associated disorder, or antibody disorder. This is a great mimicker because of the symptoms that it can cause: optic neuritis, encephalitis, myelitis, Aquaporin4 NMOSD, negative MOSD, and acute disseminated encephalomyelitis. So it's a great mimicker of our age. And this is a little chart, but I will point out some very quick things here. in that the differences on MRIs, you'll see a lot of fluffy lesions in MOG cases, and you can have short or longitudinally extensive lesions in the spine, so that's important. Whereas in Aquaporin4, you're mostly going to have longitudinally extensive lesions, whether they're in the optic nerves or cord, and MS or short lesions. And then CSF oligoclonal banding is quite sensitive and for MS, whereas less so for MOGAD and Aquaporin4. So here are some of the fluffy lesions in MOGAD that I just talked about. You also see some in the brainstem. And then optic nerves can be very angry looking, longitudinally extensive changes, and also quite a lot of edema around the soft tissues there. Spinal cord, you can have longitudinally extensive lesions, short lesions, which I haven't pictured here, conus involvement as well. And so what we do with MOGAD in the long term is still an area of active discussion. Small cohorts, the Mayo Clinic, who were able to bank serum from patients long ago and thus look at MOG titers and so forth, they've detailed on some of their longer surveyed patients that this can be a very relapsing condition indeed. Overall, we say for all comers, it's about a 50% chance of relapse, although that depends on age, presentation, etc. So treatment after the first attack is mixed. Many choose just to watch and see. Treatment after the second attack is a lot easier, right? So there's a suggestion of recurrence. Things to think about are that the MOG titers go up around relapse. They can remain persistently elevated. So rechecking around 6 months may be indicated, especially as this could be related to a relapse. However, it's tricky because MOG titers may go from undetectable to positive. And immunotherapy-wise, we've tried various things: steroids, rituximab, IVIG, etc. More recently, there's a retrospective study that suggests that IVIG may be quite effective, although we do not have any sort of prospective trials in this arena. So to finish things up, just some very high-level tips here. For autoimmune encephalitis, have a strong clinical suspicion. If that's the one thing I want you to take away from this, have a very strong clinical suspicion even before you start testing, because otherwise you're going to have a hard time dealing with the results that you get, all the non-specific results. So serum and CSF is recommended in cases of high suspicion, and sending it to Mayo is recommended in the United States due to tissue-based screening, which enables novel antibody discovery, as well as being panel-based. So in other words, that goes back to not focusing on one autoantibody because they have overlapping symptoms. Otherwise, if you want to look at GABA-A, you need to send it to UPenn. Glycine, we talked about the new commercialized test. Anti-Ma, Ta, and Zik are Athena tests. Those are not tested at Mayo. For Aquaporin4 and MOG, don't use the ELISA test. There are a lot of false positives at low titers, and it's just not a very good test in general. Don't test Aquaporin4 in the CSF or MOG, and do order cell-based assay tests, for example, from Mayo, the CNS demyelinating panel, or the ARUP version of the same thing. Now, so here's a little list. Mayo has a panel for everything, but overall, the autoimmune encephalopathy panel is one of the more comprehensive ones. You will have to keep in mind if there's a movement disorder, you are going to want to tag on the movement disorders panel, which can get GRAF1 and ITPR1 as well. So these are some of the wonderful people I work with, and I think that leaves some time for questions. So thanks so much. Okay, I just want to see if we have a chat or anything. Oh, yeah. So Dr. Sweeney mentioned a really good way to remember anti-Lgi neurological side effects, and it's also called PCA, or and PCA or C for cerebellum effect.
That was a great talk, Kadish. I'm really sorry that you have to put up with that nasty scenery every day. Um, Hopefully, I didn't leave too many messes of patients for you.
No, it's actually speaking about patients, we had a David. I don't know if you remember. I'm sure you do. So there was a patient with a brainstem disorder that was a relapsing brainstem disorder, and was undiagnosed, but I think started in 2015. And we actually in 2019, right before I left, I think we diagnosed them with MOG, anti-MOG. So yeah, just really interesting how fast things move in this field.
I think locally we only have a couple adult MOG patients who all have had, at least in my practice, have had optic neuritis as their main recurring presentation. Definitely more variable presentation in the pediatric population.
Yeah, there was that somewhat recent article, I think was by Waters, right? That looked more at the pediatric presentations, and it's challenging, right? Like how do you counsel patients? How do you counsel their families? There's a lot of uncertainty.
We do have a question on why not to test aquaporin4 in the CSF. So you might go into that just a little bit.
Yeah, so the basic reason is because it's not helpful, and it's actually even less sensitive than the serum test. And so just in sake of not mudding things and not costing the patient any extra money, and it's actually the wonderful thing about aquaporin4 and MOG are that it's a serum test, and those are highly sensitive and specific actually. So the sensitivity probably for both of those these days is above 80%, maybe even higher. Yeah, thank you, Dr. Remmel, for those kind words. It's really nice to have everyone here in the room. So it means a lot for me to be able to come back and, just a couple of years later and be able to present this.
Hey, Robert, that was
pretty good.
That was a fantastic talk.
Yes.
I really like the use of some of the new research being done on advanced imaging techniques. I thought the PET studies were interesting. And do you see any role? I know a couple of patients ended up getting epilepsy workups with MEG. Do you see any other future role for other advanced imaging techniques in this field?
Yeah, great question. So the MEG, I believe, was an outside institution. I don't actually think we have that at the University of Utah. Well, I mean, I think there's a lot to still be learned about PET imaging, the metabolic imaging types. We know it can be more sensitive, but especially when you look at the brain findings, they can be very nonspecific. And so the brain's a highly metabolic organ. And, some of the findings are still being worked out. For NMDA, for example, there's been described a relatively specific kind of anterior-posterior gradient on PET, but nonetheless, things are not as well worked out for that. So I don't know. Have you heard of anything, Chris? Are you thinking about any specific types of imaging?
No, I haven't thought of anything in particular. I know we don't always necessarily think about PET scans in these patients. I can think of maybe a couple, and maybe Dr. Sweeney can talk, or if he has any other experience. But I just thought it was a kind of an interesting thing that I hadn't thought about previously.
Yeah, and from a practical perspective, so a lot of this advanced diagnostics can be difficult for costs, for insurance approval, et cetera. For the PET scans that we do get, usually, I guess the initial test is the skull base to the eye, but so it's easy to add on the head. And in cases, it can potentially give you hints. Especially in tough cases, it can give you hints of what's going on. And the nice thing about PET also is that it's metabolic, so it's non-specific. So, even other inflammatory conditions can be on the table, right? Like sarcoid, et cetera, which can be picked up by that.
I have a question. Is there
Awesome, thank you.
any evidence of diffuser tensor imaging to predict response to treatment or predict disability? Is there any work done in that area?
Yeah, that's a great question, Dr. Plate. And to be honest, I do not know. I don't know if David or Michael, you guys know about that specifically.
I don't. It's been hard to quantify, so it has mixed utility in what I've seen, just from standardization, but I don't know anything specific.
Yeah, the role of that, I think, in clinical practice, at least in the autoimmune neurology field, is not yet well established, I would say. I think it's interesting. I personally don't see a lot of that. So what kind of challenges has the group had in terms of, working these patients up or getting studies paid for, or having hospitals, maybe cancel tests and things like that? I think I seem to recall when I was here, that was a little bit of an issue with the pathology department. There was perhaps a little bit of a concern about some tests.
Yeah, so the hospital lab really got an entire study with Anita, and has since kind of proven the utility of sending labs straight to Mayo. And so we actually succeeded, I think, in that battle on some level. So she did good work that was going to be presented to AAN. So the hospital now sends all tests to Mayo. I have not experienced cancellation of our tests because we've used an algorithm that I think is going to get published in a manuscript. From my clinic, they still default to non-Mayo. So you fight certain battles, you don't fight other battles, I guess. Payment is interesting. I was thinking if Dr. Sweeney just has a knack for finding cancer in anybody, so don't see him, come see me. But yeah, PET scans, and he and the staff I can hear arguing for PET scans frequently, and he just has a knack for finding cancer. But it's hard to get paid for. I mean, I hear the battles for PET scans especially. I think coding encephalitis, for a diagnosis that we don't know, coding encephalitis without a diagnostic code, I think really gets things moving through the insurance companies, more so than coding demyelinating disease. So that's one thing I found to be helpful of just getting the machine to run quickly, is coding encephalitis versus weakness or mental status changes or encephalopathy. That'd be my 2 cents.
Mm-hmm. Yeah.
Any questions or comments?
Yeah, it looks like Dr. Feng had a good comment there. So, one of the clinical-based screening systems, especially for epilepsy, to predicting a response to immune therapy for autoimmune epilepsy is the RIGHT-2 score. And that features a lot of, I think it's hinged on the 2016 criteria, but expands on it and really gives you a good idea of what symptoms you can ask a patient about and look into.
All right, we might say thank you. Let Dr. Kadish get to his morning, hopefully with his family before work, because he's 2 hours west. Everybody else, be careful if you're on the roads, or settle in and do your thing today. I owe you coffee and beer, dinner, whatever, when we get together. Dr. Kadish, not everybody. Although I'd like to see everybody out for coffee and beer, but I may not treat you.
Yeah, ditto.
All right, thank you.
Thank you, Robert. That was great.
You're so welcome.
Thank
Nice
you.
to see you all and hear you all.
Have a great day.
Wonderful.
You too.
Thank you. Bye-bye.
You too. Take care.